Good evening, everyone. So tonight I will provide an overview of Chapter 3. We will discuss multicultural standards of treatment, multicultural competence, the therapeutic relationship, building cultural literacy, as well as other aspects of treating children and adolescents. Again, thanks for listening. When working with children and adolescents, we must follow a set of guidelines that will help treatment flow. That's where the multicultural standards of practice come into play. As psychology has grown within an increasingly multicultural society, the field has had to catch up with reality. Our clients come from diverse cultural, racial, ethnic, and social backgrounds. If mental health professionals don't take this diversity seriously, they risk providing services that are ineffective or even harmful. That's why professional organizations have created multicultural guidelines and competencies to help psychologists, counselors, and educators offer more equitable and responsive care. There was an early recognition of cultural needs that initially were not being met. However, since the early 1990s, psychology organizations began formally acknowledging that culture matters in every aspect of practice: education, training, research, and therapy itself. Then came a turning point with the Association for Multicultural Counseling and Development, AMCD. In 1992, Sue, Arredondo, and McDavis introduced 34 multicultural counseling competencies, which quickly became foundational in the field. There are 3 domains of competence. The AMCD competencies emphasize 3 big areas that counselors must continuously develop. First, cultural self-awareness. Recognizing your own biases, values, and worldview, and how they impact your work with clients. Secondly, you need to know the client's worldview, understanding how clients' cultural backgrounds influence the way they see mental health, relationships, and help seeking. Then third, there are the culturally appropriate skills a clinician must acquire, allowing us to adapt interventions so they fit the client's cultural values, context, and communication style, rather than expecting the client to adapt to you. Now, although many of you are learning about counseling through other disciplines, you should be aware of the American Psychological Association's 6 multicultural guidelines that were created in 2003. Building on this foundation, the American Psychological Association adopted 6 official guidelines in 2003 that apply across clinical practice, training, research, and organizational work. These guidelines urge psychologists to consider cultural context when working with clients and communities, actively pursue multicultural training and education, conduct research that reflects cultural realities and avoids unfair generalizations, integrate multicultural awareness into organizational policies and structures. Here are some basic considerations in multicultural practice. To work effectively with diverse clients, clinicians need a shared language and clear understanding of core multicultural concepts. These are the building blocks of culturally responsive treatment, and without them, both the therapist and the client may miss important cultural meanings in therapy. 1. Culture. Culture isn't just about food, holidays, or clothing. It's the deep framework that shapes how people think, feel, and act every day. It includes shared values, beliefs, and practices across categories like race, language, gender, socioeconomic status, disability, sexual orientation, and spirituality. In other words, culture is the lens through which we view reality, and it influences both clients' worldviews and clinicians' interpretations of behavior. 2. Multicultural. The term multicultural reminds us that people rarely belong to just one cultural group. Each individual navigates multiple overlapping cultural identities, such as race, gender, social class, and age. This means behaviors can only be understood within the cultural context in which they occur. In therapy, the client and therapist may not share the same cultural lenses, which can create misalignment. A multicultural frame of reference helps clinicians notice these differences, adjust their conceptualization of the client's concerns, and choose culturally relevant treatment strategies. The third aspect is multicultural competence. Cultural competence is not a one-time achievement. It's a lifelong process. It involves learning how to think, feel, and act in ways that respect and integrate cultural diversity. Practicing multicultural competence means respecting diverse values and traditions, integrating multiple aspects of identity into treatment planning, building skills to work with cultural differences instead of ignoring them. Clinicians should be aware of the collectivistic orientation. In many communities of color, the focus is not on me, but on we. Collectivism emphasizes interdependence, group cohesion, and prioritizing family or community goals over individual goals. Positive aspects: provides belonging, adaptability, and strong social support. Challenges: can create cultural conflict, stress, or tension if individual needs clash with group expectations. For children and adolescents, collectivism often shows up in loyalty to family and peer groups. Therapists must recognize these patterns as culturally shaped, not as pathology, and explore how collectivism is using interpersonal therapy with children and adolescents, or IPTA for short. IPTA is a well-researched, evidence-based treatment that looks at symptoms like depression, anxiety, or disruptive behavior through the lens of relationships. Instead of treating problems as something inside the adolescent only, IPTA focuses on how difficulties show up and are maintained within interpersonal conflicts with peers, parents, teachers, or others. This approach is particularly beneficial for children and adolescents of color, as many come from collectivistic cultures where harmony, connection, and group identity are highly valued. In these contexts, when relationships are strained, the distress is magnified, not just for the individual, but for the group as a whole. IPTA helps restore relational balance, which can reduce maladaptive behaviors. Where symptoms would show up. For many young people, challenges are most visible in school and peer settings, where friendships, group belonging, and social status play a central role. Problems with peers like conflict, rejection, or isolation can become a major driver of symptoms. IPTA acknowledges this and works directly on improving the adolescent's relationships. Let's look at the treatment process. IPTA is structured into 3 main phases. Each phase has about 4 sessions. During the initial phase, the counselor would build rapport, explain the IPTA model to the client, and identify the link between symptoms and relationships. We would then start the middle phase, where the counselor will actively work on strategies to improve communication, resolve conflicts, and strengthen social supports. Once the child or adolescent has successfully completed the first two phases, we would then start the termination phase. Here we help the client to consolidate gains, prepare for future challenges, and end therapy in a way that feels empowering. When counselors add cultural adaptations, a version known as culturally responsive IPTA, CRIPTA, they align the process with the client's cultural values, worldview, and relational expectations. This makes the therapy not just effective, but also culturally respectful and relevant. It's important to remember that IPTA helps children and adolescents by targeting the social world, where their problems often unfold. When delivered with cultural responsiveness, it honors collectivistic values and supports healthier, more adaptive connections with peers, family, and community. Now, there are several areas that you will touch upon in your reading, but I did want to cover special considerations for specific populations. When working with children and adolescents from diverse cultural groups, clinicians must recognize that acculturation, identity development, and cultural conflict are often underlying sources of distress. Ignoring cultural norms doesn't just miss important context, it can invalidate a client's identity and lived experience. To practice culturally responsive therapy, it's important to understand both the strengths and challenges within specific groups. Let's start with African Americans. Some of their strengths include flexible family roles, extended kinship networks, strong spirituality and church support, and racial socialization. Parents teaching children to navigate racism with pride and resilience. Challenges for this population are deep mistrust due to chronic racism and discrimination. Therapists must validate these experiences, acknowledge oppression, and use empowering strategies to build trust. We should also consider the American Indian and Alaska Natives. Their strengths include collectivism, extended family structures, spirituality, respect for elders, and a strong tribal community identity. Challenges: historical trauma, land loss, and systemic oppression create mistrust and acculturation conflicts, especially across generations. Mental health is seen as a mind-body-spirit balance, so treatment should focus on restoring harmony. Then we have Asian Americans and Pacific Islanders. Strengths include collectivism, respect for elders, family cohesion, and a holistic view of health, mind-body connection. Some challenges may be acculturation conflict, authoritarian family structures, and racism/discrimination. Symptoms may show up somatically, for example, headaches, stomach aches. Therapists should assess acculturation and adapt therapy to fit family expectations. We have Latino, Latina, or Latinx Americans. Strengths: collectivism, family unity, familismo, warmth in relationships, personalismo, spirituality, and extended family support. Challenges: acculturation stress, stigma around mental health, experiences of discrimination, and role expectations. So this covers the lecture for this evening. I do apologize for not having a synchronous class this evening. Unfortunately, I am still dealing with health issues and I overexerted myself. Therefore, I must be on bed rest with little interaction for the next few days. I hope that I will be able to meet with you next week. I will be uploading an assignment no later than Wednesday that will be due by Monday of next week.